selfish, I'm going to go ahead and be selfish. We're going to start with the AAST today, and the presenter is going to be Dr. Josh Kronenfeld, who's a fellow in trauma and surgical critical care at the University of Miami and the Ryder Trauma Center. Josh, go ahead and present.
Thank you so much. Thanks for the introduction. Thank you to the AAST, the Pan American Trauma Society, Dr. Demayas, Dr. Salomea, and Dr. Pascal for hosting this meeting. So the case I'm going to discuss, that we're all going to discuss, is entitled Tension to Tamponade. The attempted decompression of pneumothoraces leads to cardiac injury. And I have no disclosures. So we'll start with a case overview. The learning points for this discussion, we want to recognize hemodynamically significant changes that may indicate cardiac tamponade. We want to identify the indications for pericardial window and understand the management options for a positive pericardial window. And so the description of this case occurred in the beginning of August of this year. The interventions that were performed were exploratory laparotomies × 2, a pericardial window, and then some orthopedic fixations. The primary injuries the patient suffered were cecal perforation, devascularization of the ileum, hemopericardium, bilateral lower extremity fractures, and then significant head and facial trauma. So the patient was a 53-year-old male with unknown past medical history. He presented to our trauma center after a motor vehicle collision, which then after he collided with a telephone pole or street lamp rather, the street lamp then collided and fell on his head. His airway had a supraglottic airway placed by EMS when he arrived to our trauma center. He had bilateral breath sounds that were equal with needle decompressions that were in place. He was tachycardic to the 120s and hypotensive to 83/50. He had a GCS of 3, but his pupils were equal and reactive at that time. When he arrived to us, we exchanged the supraglottic airway for an endotracheal tube. We did place bilateral chest tubes and left the needle decompression needles in place. A right subclavian introducer was placed, and we began transfusion of whole blood for the patient with good response in hemodynamics. Blood pressure was 130s. The fast chest x-ray and pelvic x-rays were negative. And on secondary survey, he had a forehead hematoma and then a left lower extremity deformity with a low ABI. I can pause here for a second. What could be some of our next steps in management, or what might be our thinking at this time?
Dr. Kronenfeld, can you pull back the last slide?
Absolutely. Here you go.
Interesting. So you have 2 chest tubes. What came out of your chest tubes?
So just air, really no fluid.
And your pericardial fast was negative?
That's correct.
And was that abdominal fast repeated a second time, third time, a fourth time?
So we did it twice in the trauma resuscitation bay. We'll repeat it later on, but now that the patient was, basically hemodynamically normal, minimally tachycardic, the low 100s, but with a blood pressure of 130. Negative fast ×2.
Since I want to be controversial and make this super fun, I think it's time, I'm going to do something crazy and scan him.
Yeah, to play the devil's advocate part onto that one. So yes, I can see how that part's going to go into the world of wild and crazy times of going to the tunnel of death with them. And I like that you said their patient's hemodynamically normal and not stable, because we know stable just implies never changing. So the only stable patient's a dead patient. But yeah, this is now the illusion of security. I'm actually very nervous really about having a blood pressure of 132/90 now after the blood came in. I'd be much happier with my hypotensive tachycardic patient. So I would be off to the operating room despite my fast being negative. You're in a bit of a tough place because you're sitting around now with your patient intubated with bilateral chest tubes, a very nice blood pressure, and that fast negative. So, as Dr. Mendoza said, yeah, it could make sense to be bringing this patient to scan, but it'd be under protest.
And I have a question. Is the chest X-ray, it was after the chest tube placement, obviously, right?
Yes, we have a chest X-ray confirming, good placement of the chest tubes. I didn't include in the presentation, but yes, and good inflation of the lungs.
So I'm going to push back on the CAT scan because I think he has several body cavities involved here. You know, the GCS3 makes me think he had, and the blunt trauma mechanism makes me feel like he could have a significant traumatic brain injury in play here. And I also think for decision making, the CAT scan seems like you have a window of time. Now, I don't know how fast your CAT scan is. So, you know, my counterparts' points are very well taken. If it's going to take 45 minutes to get a CAT scan, this is going to be a nerve-wracking CAT scan.
Yeah, so I can keep going. So we did elect to go to CAT scan. We're very fortunate at our institution. We have the CAT scanner maybe 20 feet away from the trauma resuscitation bay. You know, we were cautious, you know, certainly concerned, but we did elect to go to CAT scan. So I'll start with the plain CT of the brain. Obviously, you can see some hemorrhages within the brain. And then I'll go to this is the pan CT scan. We elected to do a CT with runoff of the lower extremity because we had a decrease in the ABI on that left lower extremity with a deformity. We have obviously quite significant subcutaneous emphysema. Our chest tubes are in the chest cavity, but the right side still has a significant pneumothorax. I'll see some stranding within the peritoneum, especially in the right lower quadrant coming up shortly. So the findings, you know, on that quick run of the CAT scan was the right pneumothorax with the decompression catheter abutting, you know, or within the lung. Multiple intraparenchymal hemorrhages with skull fracture, intra-abdominal free fluid with the mesenteric stranding, small amount of pericardial fluid, and I'll show some images on the next slide with the decompression catheter abutting the pericardium, a right tibial plateau fracture, and then again, left tib fib fractures with vascular intact down to the foot, at least through the PT. And so these are some still images from the CAT scan. So on the right-hand side, we had the catheter sort of abutting the lung. And the left-hand side, you can see the needle decompression catheter was placed rather medially and is actually abutting the pericardium or possibly through the pericardium. It's hard to say, certainly. And so we returned to the trauma bay with this patient. You know, we removed the right needle decompression catheter, replaced an additional chest tube, did get a good rush of air from the right.
Josh, why don't we let the panelists say if they would have what they would have done with once they've seen that needle. So you've given away that you removed the right needle decompression catheter. Dr. Mendoza, Dr. Grushka, Dr. Ludi, would you have done the same thing, or would you have even left it in on the way to CAT scan? How do you handle those needle decompression catheters?
You know, a couple, and just for that part onto it, I've got my writer jacket on here, so remembering the good times that have been there over a decade ago, and thanks to everyone who's still there for giving me that foundation of training. You know, we here in Quebec, so our pre-hospital system is not putting in those decompression needles, so there is some advantage to still being in archaic times of scoop and run. I probably would have left that in place in terms of going to scan, but seeing where that picture, where the needle was, I wouldn't have removed it. I mean, you don't have blood squirting out of it, and so you're not going to transduce it now into an art line because it's sitting inside of the heart, but I'd be worried about it. And then you have free fluid in the abdomen. You're hypotensive again. I'm going to the OR. I'm going to be doing a laparotomy for this patient. I'd be doing a pericardial window. And then based on what I find in the pericardial window, I would decide what I'd be doing about those catheters, but I don't think I'd be removing it in the trauma bay.
Well, to be perfectly honest, you know, the 10th edition ATLS is saying that these needles should be going in the fourth intercostal space because in the second intercostal space, they rarely go into the chest. So in my personal practice, when I see them, I frequently think they're inappropriately placed. I think they're useless. I have not infrequently removed them in the trauma bay. And I probably would have removed them in this person too. I just don't think they're doing much, especially after chest tube's in place. I wouldn't have expected this.
And I totally agree. And this is my first time in my 40 years as a surgeon that I see the catheter, the compression catheter going to the pericardium. Usually they are not in the right place. I would have been removing the after placement of the chest tube myself, and that probably had been my practice. Going back to the patient itself, I think the key point is that to get the respiratory part first, then I agree just to put in a second chest tube right there. And the pericardial window, I think, is a must to do it. And it depends what is the pericardial window is going to be the next thing to do it. The abdomen had to be assessed without any question because the free fluid right there, but they will follow the ABCD in this case that I think is a merit to go. That hypotension is still, I don't have an explanation because there's not so much fluid in the chest, there's not so much fluid in the abdomen either. Retroperitoneal is fine. And then, well, I am worried that could be something related with the catheter itself.
All right, Dr. Grushka, continue. Dr. Kronenfeld.
I'm gonna
So
once a
I'm going
fellow,
back to
always a
fellowship.
fellow.
Yeah.
So we placed again another episode of hypotension. So we elected to go to the operating room. We resumed blood transfusions again with some intermittent response in hemodynamics. We administered Keppra, TXA, and hypertonic saline on our way to the operating room, and then also let our neurosurgery and orthopedic colleagues know what the findings we had in case they wanted to join us in the operating room. And so, yeah, how would we approach these clinical injuries? I think we already discussed that. And we went to the operating room. So we started with the abdomen. We performed an exploratory laparotomy. There was small volume hemoperitoneum, not a ton, but at this point, the patient's hemodynamics had responded to the blood transfusion that the anesthesia colleagues were administering. There was perforation of the cecum as well as a bucket handle injury at the terminal ileum. So we resected this, left the patient in discontinuity. We saw a non-expanding right zone 2 retroperitoneal hematoma. We did not explore this. And then at this point, we kind of were with the patient in the operating room thinking that we were going to be performing our pericardial window. And we elected to remove the left chest needle decompression catheter at that time. Immediately, the patient became hypotensive to the 70s systolic. Again, we were in the abdomen. We didn't see any significant bleeding to explain this hypotension. We looked at we had the nursing staff and some other colleagues in the room look at the lower extremity to see if there was an expanding hematoma at the lower extremity. We did not see one. The pupil exam, thinking maybe potential neurogenic causes, was also within normal limits. So we were really left. I mean, I'll go to the next slide, but what do you think is the potential source of hemodynamic instability? Sort of discussed this, but I'm not sure if anyone has any additional points or things that they may have done different in the operating room to get to this point.
I guess I wouldn't be perseverating so much on the GCS. Once, given the fact that, the chest is in play, I usually quickly move to a pericardial window. I'm not asking that too much of my anesthesiologist to give me a pupillary exam, although I think that's not completely inappropriate. But I think the first thing you need to rule out is if the pericardium is in play, whether you actually have a chest injury, you had a huge pneumothorax, I'd still be worried that you might have a bigger bronchial or chest injury that you can, then you really appreciate. So I'd probably be moving quickly to the next cavity.
Yeah, I would agree. I mean, my concern here a lot, and based also with the imaging we had, is what's going on now in the mediastinum with that needle that's heading toward the heart. One part, we have a lot of our trauma anesthetists in our hospital. While we'd be doing our laparotomy, they would have been doing a transesophageal echo. Whether we asked for one or not, that probe would have been down there. Out of curiosity, was there any discussion about doing a TE in the OR, or did one of the anesthetists put one down?
It was not discussed. We don't, at least, seem to have as readily available TE probes in our facility as some of the other trauma centers. This was actually discussed, kind of post-operatively after the case. How it certainly would have been helpful, but no, it was not available to us at the time of the operation.
And then one more question is regarding after you placed the second chest tube, what was the result? Do you have a persistent air leak, and you have another chest X-ray to confirm that you have a good expansion of the lung. What happened after the second chest tube?
Yeah, after the second chest tube, it's actually interesting because we got a rush of air, but then there was not a continuous air leak. So it's really not, it's not sure exactly why the first chest tube wasn't really fully decompressing the cavity. There was no blood coming out of all three of the chest tubes while we were in the operating room. And on chest X-ray, again, both lungs appeared to be inflated with no significant hemothorax either.
And I think sorry, would be very important to assess if I don't have any problem with the pneumothorax, and a median sternotomy would be my next step immediately there. But not knowing what is happening in the left chest, still, I am not sure it would be any way to make a good assessment. But with the blood pressure in the 70, you need to act very fast, and probably a median sternotomy will be a good option with the injuries, that with the caveat that if it's an attention pneumothorax, I would be very unhappy with that incision.
My last
And
question. Oh, I'm
Go
sorry.
ahead. No, not at all.
My last question, I have been fooled by this. Was this an open fracture?
Of the lower extremity?
Yes.
It was an open fracture. It was a small puncture site, not a huge hematoma, but yes, it was an open fracture.
Yeah, I mean, the only thing I would say is, like, sometimes I've not looked at the leg when it's covered by the drapes, and I have had some significant blood loss from an open fracture before. So the last thing on my mind.
Yeah, and we did, and I appreciate the comments from everyone. We did ask the nurse to kind of lift up the drape, and we did take a look at the lower extremity, and it looked okay. There was really no significant bleeding and no hematoma.
And I may have missed before, and during that time, was there an increase in output from the left chest tube or not?
No, neither chest or none of the three chest tubes actually ever put out any blood. I mean, just air. And then after the initial chest tube placement from all three chest tubes, there was no air leak. The air stopped.
All right, proceed, Dr. Kronenfeld.
Yeah, so we opted because we were already in the abdomen. We performed a subxiphoid pericardial window. When we encountered the pericardium, it was very tense, difficult to enter. But when we did enter the pericardium, there was a release of blood, blood-tinged fluid, with immediate improvement in the patient's hemodynamics. And we thoroughly irrigated the pericardium until it was clear.
Okay, don't advance your slide, because there's an opportunity to ask people what they would do. Okay, thank you.
So fantastic, and forget the last part onto it. Despite the jacket that I am wearing, I can say that here, if I were to irrigate out the pericardium and leave drains, while it's Canadian, so, very nice and not, mean in any way, I could possibly be tied to a cinder block and thrown off the Champlain Bridge. So I would do a sternotomy. However, yeah, man, I mean, I respect that data that's come out of Ryder a number of years ago, and also with partners in South Africa, and there could be a role for it, but I would be lying to say if I would do that. I would have seen that and said, we're doing a sternotomy, and go from there. And then to our residents, talked about the paper that a group in Miami had published and how this is an option, but we can't do that here because it doesn't have external validity for our, Canadian context.
It's very tempted just to do the lavage, because it's in a very small needle, and you will figure out if that was the cause, and maybe it can be sealed by itself. Obviously, the clinical presentation is going to be very important. After the blood, I suspect that the patient became very stable, well, not stable, but hemodynamically okay. And then it's a very tough decision, but I will be aggressive, and I will go for my pericardial, my medial sternotomy there, because even sometimes the pneumopericardium could be caused without any bleeding too. And then being in the operating room with the abdomen already open, to take the risk, I don't know.
Yeah, I mean, I feel like we this is the crux of like we've had something very similar recently, and I'd love to tell you, like looking at the mechanism, it's a blunt mechanism. The odds are this, you know, that perhaps the sternotomy is not indicated. I think it would depend on the quantity of blood coming back at me, you know, the patient's hemodynamics. I would need them to improve drastically and quickly. If they remained unstable, I'd have such a low threshold to proceed with sternotomy.
Yeah, you know, it's one of the nice parts of these discussions. Like I want to tell the truth. We would do 10 times out of 10, we'd be doing a sternotomy.
All right. So,
And are we going to find something for it? I don't know. We do a lot of echo. Someone mentioned in the chat there about pericardiodoscopy, which I've never done. Has anyone ever done that? Put a scope in and take a look around the heart? Okay.
Absolutely not. I'm in a county
Okay.
center. I mean, like, I'm lucky to have a TE as well.
Yeah, yeah. Because I don't know about the telescope in the heart.
Dr. Kronenfeld, how did it go so we can make sure we leave enough time for the PTS case?
Of course. So, as I mentioned, the pericardial fluid, you know, became clear. We continued to irrigate. Patient's hemodynamics, as you guys have kind of alluded, you know, they completely improved. His blood pressure was in the 120s, heart rate in the low 100s. We had a little bit of luxury because the neurosurgery team actually came into the operating room to place an intracranial, you know, ICP monitor. And so we had a little bit of more time to kind of just sit there and watch, you know, the pericardium. And there was no significant bleeding, really no bleeding at all that was coming out after we did our initial, you know, pericardotomy. And so we elected to place a drain, place a temporary abdominal closure, and transfer the patient to the ICU. So over the next 2 days, or really about 36 hours, the patient's lactic acidosis improved. He was normothermic, off pressors, no additional blood transfusions. His ICPs, you know, 4 to 24, slightly worsening of the bleed on CT scans. We continued hypertonic saline infusions. And we did an echocardiogram, a transthoracic echocardiogram at bedside, which demonstrated no pericardial fluid, normal ejection fraction, no wall motion abnormalities, no valvular abnormalities, and normal left and right heart pressures. So I think in the interest of time, I can keep going. We said, when should we return to the operating room? You know, basically the patient now has been adequately resuscitated. So we returned to the operating room to perform our anastomosis. We again looked at the pericardium. There was no additional fluid, blood clots. We removed the drain. We closed the fascia, loosely approximated the skin because of the colonic injury. And then when we finished our operation, the orthopedic team came in to externally fixate the extremity fractures. I have some more slides on the rest of his course. I'm not sure if you want to have any discussion right now based on our findings before I finish up.
Quick question.
Yes.
Did you close the pericardium?
We did not. We did not close the pericardium at that time.
I think it's 12/22, and so I mean the interesting thing about this case was the fact that you chose to do the pericardial drainage. The rest is pretty much routine. I know that. Do you have anything about the literature for the pericardial drainage? Because the rest is not remarkable, right, Josh? Am I missing anything?
No, you're correct. I mean, I put up the paper that came out of the Ryder Trauma Center in 2012. Put up the abstract at least, looking at you know, patients who have fluid in the pericardium and then go on to sternotomy, and then the likelihood of actually finding a positive finding, something to actually intervene on, which really led to us saying that, or at least the institution saying that you could, you know, if you irrigate the fluid. And it's clear you could consider in the appropriate patient population. Again, this is someone who's hemodynamically normal, you know, that doesn't have any other distracting injuries, that really just has this as an isolated finding, and then responds well hemodynamically. That you can, in some instances, you know, just leave a drain.
And then the best work came from Navsari and Nickel in South Africa. Do you have those or no?
Don't have those. I have another study, this study from Tennessee. And then I put up another study from this is from UNLV Nevada about their algorithm for managing these positive.
But it's all sort of really evolved from the time when, you know, we looked at it and others sort of It started appearing in algorithms. We published a textbook chapter. It's there. So it's slowly creeping into it. But there was a prospective randomized trial in South Africa. And that seems like the best one, although there was something special about their management. The patients actually, I think they're so busy that the patients sat overnight in the ICU. If they were stable, they didn't go straight to the OR, they sat overnight. So they were already sort of self-selected survivors. But in a case like this, where you suspected it was a needle hole, it goes back, the first angiograms, there were ventriculograms, were done by intentionally puncturing the heart to shoot a ventriculogram. And that was done in Cuba, in the 60s. So nothing new under the sun in saying that little holes can heal. Is there anyone else that wants to make any comments, or can we turn this over to the Pan American?
I think there's some comments in the chat.
Well, there's a long comment from Dr. Piana about a paper.
Just to copy that, we published this in the Pan American Journal of Trauma, in the Journal of the Pan American Trauma Society. But as you said, this is a patient who has a stab wound to the box that is never unstable, which is very different from the patient you're talking about here. And most of the South African experience is also in patients who are stable, who never had hypotension. So when you do that, Alberto Garcia has written this little paper that allows you to kind of calculate what are the chances of that needing a thoracotomy. Unlike this patient who is unstable in the operating room, you may be forced to do what you guys did, and you were lucky that you didn't have to open the chest, perhaps because the small needle didn't cause an injury that needed an operation.
This is going to remain controversial probably for another 20 years until there's so few sternotomies that, it's sort of like open chole. It went away, and then it really went away because none of the new trainees know how to do it. So it's really gone. And it's going to be like this. It's going to be a bunch of years, but it's evolving. I'll tell you, for the first 20 years of my career, I looked at all the things in the meetings about update and this and updating that. And I felt like nothing was ever an update. It was just the same old stuff. But now with a 30-year perspective, things have changed. It's slow, but change happens. And this is changing also. I think we should, I want to thank Dr. Grushka from Montreal and Dr. Mendoza from San Francisco for their volunteering to participate, Dr. Kronenfeld for presenting. He's going to be a superstar. And I want to turn it over to the PTS for the rest of the conference. Thank you.
Thank you, everyone.
Okay. Now we're going to change to Dr. Francisco Collett, Professor of Surgery, the Hospital das Clínicas de São Paulo, who is going to present a usually excellent case. And we are continuing with the same panelist. Go ahead, please, Professor Collett.
Okay. Good afternoon for everybody. I want to take you, thanks for the presentation, this case. I want to take Antonio and Dr. Jose for invite me to the presentation in this meeting. I presented last year in the WGST Congress a case. So I think I go to present a case, an interesting case, because sometimes you have asked for pericardial windows, for pericardial heart injuries. So let's go to show something different, to think about. I go to present a case. Let's go. It's a pneumopericardium caused by a penetrating wound. What to do, a clinical or a surgical treatment? It's very interesting because I never see this before. So I have a 34-year-old man. This started the emergency. He is a homeless, and he has a chest penetration stab wound. And they rescue by a transport to the hospital by a basic health hospital. There is no doctors. They put the patient in the ambulance. It took is the emergency room. In the emergency room, you can see airways is patent airways open, speaking normally, respiratory rate is 60 EPM, saturation is 96%, vesicular murmur present bilaterally, heart sounds is normal without murmurs, no jugular vein distension, blood pressure was 130 by 67 millimeters of mercury, cardiac case 85 BPM. But in this hospital, you don't have ultrasound in emergency, you don't have fast. So you have only this. You have a CT, but you don't have fast. Glasgow, Pope score is 15. Pope is a Kronenfeld reagent. He has a 3 centimeters long injury in the level of the third left intercostal space near the sternum. I go to show the patient. Here you can see the patient. You can see the injury.
So this is the
yes.
patient.
This
is the patient and the injury.
Yes, it's very interesting injuries because it's very big injuries and the penetration in the chest. But it's not sucking injury. There is no air from the injuries. So what to do with these patients now? You can observe, you can make a exam, you can make a surgery, maybe anything. What to do with these patients when we receive this patient?
Who is first? Ludi Mendoza Gushka.
Well, if it's not, if it's not broken, maybe I don't need to fix it. The guy sounds like he's GCS 15, normal vitals that you described so far.
Yes.
I haven't seen the CAT scan results. I don't have an ultrasound. He's comfortable. So I think I have time to observe this man. Now, would I want to observe him at this facility? Probably not. I probably would want to send him somewhere where I could do serial ultrasounds, or at least get a good ultrasound. Is that possible?
No, I think I agree. And this day for us is a little difficult to make the assessment what to do without the ultrasound in this case that I think is extremely important. I don't know what else do you have in your facility, but if you don't have any pneumothorax right there and the patient hemodynamically stable, and in the chest, usually you don't have to do any exploration. That means you have to put your finger to see how far it goes. Don't be tempted for that. You're going to have a little more bleeding, but you don't have ultrasound. I don't know. But a patient is hemodynamically stable. And I think to send this patient in another facility that looking for ultrasound is a little dangerous. But I will continue observing the patient. We get my chest X-ray. I will do the full workup and just to see how he does.
Yeah, I would say also I want to know what the chest X-ray findings are. I'm concerned here whether or not there'd be any left hemothorax component. And the only other thing then to go in a different direction than the other panelists, of something you could do is that if we are electing to keep the patient in that facility, though I agree completely with Dr. Mendoza, I'd kind of be wanting maybe to go to a different facility, is put in a left-sided chest tube. At least it can let me know whether or not anything will be accumulating into the left chest around the time, and I'm sure getting x-rays at different intervals is also going to be challenging. So at least having that tube in place if something is now decompressing into the left chest, I could know about that. It's the only other thing I could think about perhaps offering at this time. But again, those vital signs are all normal, but I am uncomfortable in that normal situation because that's bad things are in that trajectory.
Well, with the problem that you already show in the first slide, I will get a chest X-ray just to rule out a pneumopericardium.
Absolutely.
Okay. Let's continue. I think it's very important. I have only the sketch of the CT is not very good to see, but I put here, but you cannot see something important in this sketch. So what to do, we have to ask, I have observation surgical image exam, that the questions I make there before, but I think these patients need to go exam. I don't have, in this hospital, I don't have ultrasound in the emergency room. I think it's very important, don't put your finger into the wound in this patient. Sometimes people try to put a finger and that's not good. It's maybe a problem with this patient. They have a very, very big problem. So I think it's very important. I put these patients to go to a CT scan. I go to show the CT. You can see here the CT. You can see air on the subcutaneous on the here. Here you can see air around the trachea, air behind the sternum, a pneumomediastinum. You don't have air or pneumohemothorax. But you can go to see here now, you go see air in the pericardium. Here, oh, this is a very beautiful image. You can see air in the pericardium and air in the mediastinum. Then I go to make you to see the reconstruction. Here you can see the big air in the pericardium. The lungs is normal. Emphysema on subcutaneous. And here you can see again, can see in the sagittal position, you can see the air in the pericardium behind the sternum. You go to see here. And now, that's the great problem. I don't know what to do. It's very rare situation. You have a penetrating injuries and maybe air in the pericardium. What to do? So I think that here, and then I have the patient is stable. You have these injuries in the zilial area. You can see a pneumopericardium. What to do with this patient now?
So it's a good pause and a nice pregnant pause for it. So I think because it's tough. I mean, that air is in the pericardium because there's got to be air from the outside world going through that wound through a hole, now going to the heart. There's an injury. And again, I don't know the right answers. The thing, I just know what would end up being here. Yeah, granted, based on your hemodynamics, now the patient is, we could have this patient in a monitored setting and observe them until something happens, but I don't know if I want to be there when just something bad happens. I may get a drain into that left chest and very well bring that patient to the operating room and start off with doing a pericardial window. I know I'm going to get air that's going to come out. I'll see if there's going to be blood as well, and then go from there. But without knowing how the story ends, an honest answer, that's what I'd end up doing.
Okay,
I'd be very
so
uncomfortable just watching him.
I have to be fun and disagree with Dr. Grushka because that would be boring if I agreed with you. But I think, maybe this is very, very silly on my point, but I see no blood in the pericardium. I see air. I know I have a wound, an external wound. So I think in some way I feel reassured that I don't see blood. I have no reason to think I have a pericardial injury. It's a high pressure system. I would imagine that I had an actual cardiac injury. I'd have some blood somewhere. I see no blood in the left chest. I see no blood in the right chest. I see no blood around the pericardium, and his hemodynamics are excellent. That being said, the future is unknown. In the event that things got interesting, is this facility the best place for me to be proceeding with advanced maneuvers like a sternotomy? And if he does develop a pericardial effusion, which he might, I think he's at risk for developing like a pericarditis in the next couple of days, even if he doesn't have a cardiac injury. So is this the facility ideal to follow him? Because he may develop tamponade, even if it's not a bloody, hemopericardium. He could develop pretty symptomatic effusion in the next couple of days, and I'm not confident this facility is ideal for me to follow.
Well, let me tell you what I will do in my service. And I see this in the CT scan, and then patient hemodynamically very stable, good map, not tachycardic. I got my smartphone and I go to the web and I look pneumopericardium treatment. And then I can find an article from South Africa and telling me a little what I should do. And then it's controversial, but there is a 10% of the time that this is a must to do on a pericardial window. This is a yes or yes. And then, and about 10% of the cases with the pneumomediastino, that they can develop an delay tension, pericardial tension. And then I think the pericardial window should be something that should be done. And then these cases for the fellow, for the resident, you have time not to have to invent the wheel again. You can go and do very fast and just to get in these days what the literature is helping you to do these cases. If you and then in the board they can tell you don't have internet, and then you have to go just to take your own decision. But I think the pericardial window for me should be something that I will perform.
Okay, may I
And
continue?
maybe to WhatsApp to Colette and ask about this case.
Okay, I put the options for this patient that I will comment, and I decide to make a pericardial window. I have a hospital that I don't have ultrasound, maybe some problems in the evaluation of the patient. So I make a substitute for the pericardial window. Here is I take off the sulfoid, you can see the pericardium and can see the abdomen. Here you can see now what's happened. I go to open the pericardium. Yeah, you can see. I have doubts that there is no injuries in the pericardium, some blending from the pericardium and the air, because very difficult to see in the CT. So I decided to make a pericardial window, and I find air and blood in the pericardium. So what to do now with this patient?
Does it irrigate clear?
Treatment? Yes, I put in the options, but what to do?
So I would do a sternotomy, but if we want to go with the CME and that I learned something from the last case, then yes, you can go and irrigate and clear it out. But truthfully speaking, I would do a sternotomy.
Again, I would use, hemodynamics are our friend. We should use them in the clinical context of what we're dealing with. I think if we have time and the guy is not decompensating, I think this is what the South African study was referring to, the penetrating trauma patient. So theoretically, yeah, if he's hemodynamically normal, this is the one you could irrigate and see. If it continues to be bloody, if he has changes in hemodynamics, this is the guy to proceed with sternotomy.
And I think we had a CT scan that didn't show so much clot inside. And if the pericardium was very clear when you go in, there was not any bulging. That means if you open the pericardium and you are sure there is no blood and you do the lavage, probably I will go just to be conservative and not to do any further.
What did you find?
Well, so I decided to make it this way. I think it's very important, very different because it's a case very rare, and that I think it's strange. Here I make a sternotomy in this patient, and then you can see here, you can see the injuries of the knife here, the pericardium. Wow. Sorry. I go back and then you can see here, you can see the knife is very big knife, who can penetrate in the heart. I open the pericardium. Here you can see open the pericardium. There's blood, clots in the pericardium. Here. It's very difficult. My scissor is not very good. Can see, is the problem. But you can see here, I can take off the clots. Usually have clots around the heart. And now I can find an injury on the, I think is the right ventricle near the pulmonary artery surrounds. You can see, go to see here, I put the pad. You can see here, I'm going to show, there is still blending, not too much, but still blending. And here I go to show, it has a linear incision of this area here. You can see here. Now I compress his stop to blending. Is a injury of the right ventricle and near the pulmonary artery. I put 2 stitch and then close the hole in the heart. And the patient was treated. In these situations, I prefer to close the pericardium because it's very easy, and to put a drain in a retrosternal drain. I make fenestration of the pericardium, and I close it and put a drain. This patient has a good evaluation and discharge at the 6th post-operative day. So that's the thing I put. If you have any questions about the case and what to do, I think it's very rare case. And sometimes pneumopericardium may be associations, pericardium. Sometimes it's very difficult to do image exams to show this. I think with the ultrasound, when we have air in the pericardium, sometimes it may be difficult to evaluation the pericardial window by ultrasound. So it's very important to do. And I have to show the case for this moment. I don't know that there is a heart injuries in the other case, pericardium, but I think this case is very interesting to be together. Thank you. I think Dr. José Pascual asked.
I have a question. We know these articles from Miami and from South Africa, but for the residents that are graduating general surgery in training, in the absence of an ability to do an echo in a stab wound to the box, to me, a pericardial window is going to be the standard, whether you do it transabdominally or percutaneously. But I don't know, and I'm willing to accept other opinions, but I don't know that we should teach that maybe observation is one branch of the options. Thoughts?
One thing I'd say is Quebec and Brazil for the win. You know, Quebec's been screaming about a sternotomy the whole time, so you've proven your wisdom.
Une sternotomie en français.
But I think Dr. Collett found a wound that didn't need sutures. It was a non-transmural wound.
Well, that was going to be my question about the depth of penetration of that wound. I was curious.
And then my question again, I don't know if I misunderstood, but I understood that the pericardial window was negative for blood.
This pericardial window is not negative for blood, it's positive for blood air.
I'm sorry, yeah, okay. And then I will probably summarize my learning from the day. And I think from the first case, I don't know how many of you guys are going to leave the compression needle to get a CT scan. After all, you have already the chest tube in, and it's not an usual location. Maybe it will be beneficial to learn that the patient is hemodynamically stable, you can leave it in, because that wasn't a good lesson to learn. And then it was interesting to see, because I was thinking in the past when the central line catheter, they were stiffer. There were some description from penetration of the, especially in the right atrium too, and they were managed in conservative too. And then this is something that the physiopathology could be a little similar from the perforation from a central line that was so deep inside that is described in the literature. But thank you very much.
Make a comment. This is Dr. Rodriguez. I'm allowed?
You are allowed, Dr. Rodriguez, always and every time.
I love you too. Well, I have a comment. You know, the devil know better because he's old, not because he's the devil. Since I did 40 years trauma, let me tell you what I learned. I used to teach that any wound, no gunshot wound, but stab wound in the box is a hard wound until proved otherwise. That's what we taught the rest. That was the dogma. Of course, this day, you know, to become professor, you had to write controversial things. The more controversial things, then somebody write against you, and at the end, you had a big city. Okay, but that's what we taught. In this case, in this patient, I know he was stable, you know. I know you're claiming that you didn't have in Brazil money to buy a sonography, but that's what you guys don't pay. But the Pan American, the doctor, he was complaining that nobody pays, you know, the quota, you know, the claim. So I think in this case, from the beginning, I said this patient is going to have either minimal a pericardial window, minimal, and then in the sternotomy. You know, this business all about is very interesting. I taught for 30 years, I was in shock trauma. All these guys from Canada, you know, Boulanger, and everybody who came from Canada, you know, can show shock trauma. When we do a window and we saw blood, obviously, we used to do mid-sternotomy. If we lavage and keep blood, sternotomy. We didn't have this business of leave it in. The South African, remember, endometritis are characteristic for one thing. There is no follow-up. Only 30% people will follow up. So don't know what happened after that, you know. So, but I am a believer that the future, you know. Remember, sonography is these days, most people have sonography. Conclusion, we have to be very careful what we say in Latin America. Because in Latin America, not everybody has an ICU there to follow a patient. So to irrigate and leave it alone there is dangerous unless you have somebody going to follow that patient. Otherwise, we'll die in the middle of the night. So I learned many things here. I like the Canadian guy, you know. I know whatever I taught there is still follow up there. We are aggressive.
Just the lung center is a unit that we you know, like is made to treat patients with lung, pulmonary, and chest problems, and we can, if you think would be okay, you know, after you know, review the case and see if we can get their transfer here. All right. Well, I will.
Hello.
Is that someone from our conference, or is that, I think, Antonio, I think your mic is open. Are you talking to someone?
Yeah.
Okay.
All right.
I think, you know, the point's well taken. I think it is risky to avoid or not explore a vulnerable population, particularly if you, especially, this is true everywhere, but probably especially in Latin America, where follow-up is maybe not available, very unclear. And in our patient population, particularly the homeless, it really is unclear whether we're going to be able to keep, you know, keep tabs on them going forward. I think once you've committed to a window, you're in a, you know, particularly for air, when you're right about the ultrasound, you're not going to be able to evaluate really well through the air. That's going to cause problems with the ultrasound. So I think my point, what I'm taking away from this conversation is for the vulnerable, or when there's any question in regards to follow-up, perhaps drainage is still risky.
Yeah, no, I think they're great cases, and I wanted to thank both presenters for doing that today, and a big thank you to the AAST and Pan American, Dr. Namayas, for inviting me to join the panel. It was a pleasure. And I think one thing that, you know, for the trainees that are on the call, a lot of that is to remember, you know, penetrating injuries to the cardiac box what to go with. Well, what are my hemodynamics? Hemodynamically abnormal, great, that's easy. We know that patient's going to be in the operating room getting their sternotomy, but really, you have someone now, you have to evaluate your hemodynamics. Where is the injury? What does my pericardial fast tell me? And ultimately, if you don't have all of those other adjuncts available to you at the end of the day, and I agree with Dr. Rodriguez, it's that it's a cardiac wound till proven otherwise, and you got to figure out, how am I going to prove that? And always be aware of the pericardial fast that's negative with a left-sided hemothorax. Because you got that injury, you have a left-sided hemo, your pericardial fast is negative, it doesn't mean your heart's okay. Your heart might just be dumping out into the left pleural space. These were great cases, really nicely presented, and thanks for letting me participate.
All right, I have nothing else for the AAST side. Juan Carlos, anything from the PTS?
I have a question.
Okay.
Go ahead.
So if the pericardial window, as Dr. Mendoza suggested, had only shown air after that CAT scan, I think that's a valid point. The fact that there was blood makes it go into one branch where sternotomy is heavily favored by everybody, but not everybody in the group. That's fine. But if it had only shown air, and would most of the panelists agree at that point that a drain in there, drainage catheter placed to the pericardiotomy was sufficient? Or would people still say, with air only coming through the pericardial window, they would proceed to a sternotomy? That's my question.
And I think Jose was exactly what my point, because I understood there was only the pneumopericardium. And yes, that I reviewed, there are 27 cases in the South Africa experience. And they have like a unstable, there's no question you go. And the stable, they did the pericardial window and they did the drain. And then that I mentioned, they put a drain because there was a 10% in the group they didn't put a drain, that they have a delay tension from the pneumo. And then that is on 27 cases that they refer. And I think, yes, it's a little controversial, but this article is very sustainable with a number of the cases that I will encourage if there is only a pneumoperitoneal that is different. If having a peritoneal lavage with a positive, that is, I totally agree with the rest of the panel.
Using the, again, the American experience, if I had air only, I would not proceed with a sternotomy. I would place drains, and that would be all I would do. Blood, I think, for the vulnerable, for someone you can't follow, I think sternotomy should be considered for someone that conditions are not ideal for consistent follow-up.
Yeah, I think so. If it's just air that's coming out, now you're either having, basically just getting flatulence that's coming out of your pericardial window. I guess, yes, I'm okay with maybe some drains and we can wait and see. But blood, we got to open them up. And just on the imaging part, to see air in the pericardium, I got to go with the same point and Dr. Rodriguez had mentioned, air is going to make it very difficult to interpret your pericardial fast. So if we're taking a different scenario now and we're doing a pericardial fast, we're seeing a bunch of air, looks like there's pneumomediastinum. Well, I'm saying that that's an equivocal fast. I can't say anything about it, and I'm going to do my window. Choosing the lesser of two evils is still choosing evil. So I want to leave that OR knowing that I've cleared everything. If I'm doing a window and there's a bit of blood, I'm still in this day of today, I'm going to open up that sternum, but I will stay true to my fellowship and always quote the papers that came out of Ryder. I just will open up the sternum.
Okay, we are in time. Maybe Antonio want to close?
Yes, I will let Dr. Pascal close just to say, from the Pan American side, has been an amazing year. We have completed 1 year of these meetings with WST. A lot of teaching, a lot of lessons learned, a lot of collaboration. This global collaboration is amazing. We really enjoyed that. And Dr. Pascual and I lead this process throughout the year, had a lot of challenges, but you could not make this happen without the work, the people that work behind the stage, right? So Brea did an amazing job, Gladys as well, Kevin, when you need like to step on to security, Kevin's doing an amazing job as well. But I'd like to say a special thanks to Liliana. Liliana is here. Liliana went through a lot of things throughout this year. She always stay with us. She always try to do her best for having this meeting happening. And Liliana, I would like to say thank you very much for working with us to make this happening week after week, okay?
Thank you. Thank you, everybody.
Okay. So, Pascal, back to you. Thank you.
Thank you, Liliana. I know you've put a lot of work working with all the international presenters and panelists over the last year. Thank you. So not to belabor things, we're at 1 o'clock, top of the hour. Excellent work, Dr. Namias and Dr. Salamayan, moderating an amazing panel and 2 amazing cases. Look forward to seeing some of you at AAST next week. And thank you. We're going to continue with this effort at least for the next year. And if you have any suggestions to Antonio or myself, please send it to us by email on how we can do this process better. Sharing on the 12 or 13 years that the PTS has been doing that and only the 1 year that the AAST has joined. Thank you, everybody.
Thank you. Bye-bye.
Bye.
Thanks, everyone.
Bye, guys.